Welcome to Healthy Lifestyle. I'm Lorianne Casdia. Our goal here at Healthy Lifestyle is to inspire, educate, and empower you to fulfill a healthy, emotional, spiritual, and physical life so you can feel empowered to live the life you have always wanted and dreamed. Today, we have on our show, we're very fortunate to have on our show from our great friends from Northwell Health, is Dr. Goncalves. Did I say that right, Doc?
Yes, it's John Goncalves. That's correct.
John Goncalves. It's wonderful to have you on. And you are a cardiothoracic surgeon, correct?
That is correct. Thank you for having me.
Oh, please. Thank you so much for being on. So tell us what a cardiothoracic surgeon does.
So a cardiothoracic surgeon we specialize in the surgical treatment of heart disease, lung disease, and even esophageal disease. So pretty much any surgery above the diaphragm in the chest. So that's cardiac surgery, so the classic open heart surgery you hear about so often in America and Western society. Unfortunately, we're an obese population that likes to smoke, so there's the heart disease, but also lung disease. So whether or not that's treatment for lung tumors and so forth, but also sometimes pulmonary or lung infections. And then the esophagus, the tube that brings food down from when you swallow down to your stomach, passes through your chest. So some of my colleagues, I do not treat esophageal disease, but they specialize in the treatment of both benign diseases of the esophagus, such as reflux, as well as malignancies of the esophagus. So pretty much chest surgery, which is above the diaphragm.
Understood. So you have just joined the Southside program just a few months ago, right?
I joined the Northwell family and Southside just about 5 months ago now, yes. Wow.
Okay. And where did you come from?
So I started my career, I trained at Cornell Medical Center in Manhattan. I was there for 9 years, training not only in cardiac surgery, but lung surgery at Memorial Sloan Kettering Cancer Center, but also at a subspecialty in aortic surgery. And I'll define that a little later, I guess. But then I started my career at Winthrop Hospital in central Long Island. I was there for about 13 years. And I was recruited to New Jersey to run a program in northern New Jersey. And then about a year ago, Alan Hartman, so the chairman of cardiothoracic surgery for the Northwell Health System, called me and made it difficult for me not to come back to Long Island. So I'm very glad he called and brought me back to Long Island.
Nice, very nice. Now, are you heading up the program over there, yes?
Yes, I'm the chief of the cardiothoracic program here at Southside, working with Dr. Robert Kalimi, who's the chairman of cardiovascular medicine here at Southside as well.
And this is actually a very timely conversation because it is Heart Health Awareness Month, and not easy to say, by the way. So that's an exciting thing. So I want to jump in here because I know I'm getting some questions from some of our listeners. And one of the things that I often get questions on is symptoms. So what are the symptoms if someone's having a heart issue?
The classic symptoms that you hear about are chest pain. And chest pain, you have to be careful about, what does pain mean? Most patients report pressure in the chest, or they'll describe, doc, I feel like I have chest books sitting on my chest. So it may not necessarily be a sharp or a stabbing pain. It can be, but the classic quote-unquote chest pain from a patient saying having a heart attack or angina, as it's called, is usually more of a pressure symptom. Patients who have a sharp pain, that can be indicative of a problem with the aorta. And some patients, such as diabetics, they can experience no pain at all. Or they could have shortness of breath instead of pain. So it could be variable, and some patients can have indigestion. You see on television a patient in a restaurant all of a sudden having a heart attack, and that can and does happen, and indigestion can be disguised as a heart attack as well.
So how does one know if you're having symptoms for a heart attack?
Well, I think you have to put it in context with your age, your risk factors. It's very frustrating when I hear of, say, a 65-year-old, somewhat obese patient with diabetes and high blood pressure, and they report that they've been taking Tums for the past month for indigestion, and they thought that they were had reflux or something along those lines, and actually what they were having were stuttering heart attacks, all along. So, I mean, if you have a family history and you're in the, kind of mid-age category, if not in your 65 to 70 age group, certainly if you're a diabetic and you're having, any sort of chest pressure or shortness of breath, that's not something that you say, okay, I'll eventually make an appointment to see my doctor. It's something that you really need to address in earnest and be seen.
I appreciate that. Thank you. So let's just discuss the aortic disease program that you have there at Southside.
Excellent. So Northwell has a Center for Aortic Disease. It's spearheaded by my partner, Dr. Derek Brinster, who's an excellent surgeon. He's primarily based at Lenox Hill, which is part of the Northwell family on the Upper East Side of Manhattan. And he also treats patients at Manhasset. I was brought to Southside to expand that program into the eastern region of Long Island. And to partner up with Dr. Brinster. And we really treat all aspects of adult cardiac surgical disease, but also specifically aortic pathology. And that ranges from aneurysms sitting right at the base of the heart, what we call the aortic root, the aortic arch, which is the aorta is the main blood vessel bringing blood out of the heart into the body, and all along the aorta you can develop aneurysms, which are abnormal growths of the vessel. So typically, when you talk about aneurysms with patients, they think of aneurysms in the brain, or they think of aneurysms in the belly. For myself and Dr. Brinster, we specialize in treating the aorta right as it originates from the heart, comes up and over what we call the aortic arch, where the vessels feed off to the arms and the brain, and then down into the chest, called the descending thoracic aorta, which then, of course, leads to the blood vessels into your abdomen and down to your legs. So we specialize in not only the entire aorta, but really focusing on the diaphragm up.
I understand. So you've been doing this for quite some time, and you've done a lot of surgeries. Do you do, obviously you do aortic valve replacements, right? So what's the difference between the traditional one versus the conventional surgical of AVR versus the aortic valve replacement?
Yeah, you're highlighting what I oftentimes tell patients, that I explain to them that I'm a plumber, and the heart's is the pump, and the aorta is the pipe, and what sits in between the pump and the pipe is the valve. So treating the aorta is really treating the pathology of the pipe, the main blood vessel. Treating the valve is sitting between the main pumping chamber of the heart, the left ventricle, and the blood vessel that feeds the body, and that's the aortic valve. And sometimes it's hand in hand. You treat the valve with an aneurysm or with the pathology of the aorta. But for many of our patients, just from advanced age, the aortic valve becomes calcified and tight and diseased, or it may leak, and you need a new aortic valve. So the gold standard, and it remains a gold standard to this day for the treatment of aortic stenosis, so a tightening of the aortic valve, is conventional open heart surgery. And that is an incision in the chest, and we could do it both with a standard incision or with minimally invasive incisions. But that's where we actually stop the heart, open the aorta, remove the old aortic valve, and sew in a new valve. And then there are different types of valve. There are mechanical valves. There are tissue valves, both bovine, made from a cow, and porcine, made from a pig. But that's the gold standard operation. It's been performed for 30 years. It has excellent results, a very good safety profile, with the risk really of, depending upon the patient population, of about 1% for the operation. Now, we have a new procedure called the transcatheter valve replacement. So that's where we can replace this valve from a needle stick in the femoral artery in the groin. So, does that mean you don't have to crack open the chest anymore? Oh, I love when you say crack open the chest. It's a pet peeve of most cardiac surgeons, but you're correct. We do not need to make an incision in the chest, and that's where we go. It's far more minimally invasive, with a puncture in the femoral artery in the groin. Now it's a bigger catheter, so you need to have larger arteries, and we're able to bring a valve up from the femoral artery in the groin all the way around to where the aortic valve sits. We place a guide wire through the tight aortic valve, and then we deploy a new valve within the disease valve. So we're not removing the disease valve. We're placing a new valve inside of that. And we started doing this. Go ahead. I'm sorry.
So if I were to do a less technical visual for our listeners, it's almost like I'm going to use a straw, and then we're going to take a thread, and we're going to kind of pull that thread through the straw. Is that basically what you're doing?
That's correct. We take basically a wire, but that'll be the thread, and under X-ray guidance, we pass through the valve. So from the aorta, we pass the tight valve, and we bring that wire into the main pumping chamber of the heart. So once we have that wire through the valve, we use that wire to come up and around and deliver the new valve into the appropriate position.
And this is while the heart is pumping?
This is while the heart is pumping, oftentimes while the patient is just lightly sedated.
Really? So is this different than what has happened in the past? I really haven't had a lot of exposure to this, so I don't know what the past versus what we're doing currently. So there's obviously been a lot of technical improvements because you're not always making incisions into the chest anymore. You're going through various valves. So is this more common than not?
It's becoming increasingly more common. So again, the gold standard for many patients, and this is what's kind of hard right now to educate patients as to what we believe is the best treatment option for a particular patient. The gold standard remains conventional open heart surgery for low-risk patients, and especially young patients.
Why is that?
We started doing transcatheter valves first. All of the clinical trials started with first we started with the sicker than the sick. We started with inoperable patients. So patients who classically, if they were referred to a surgeon, the surgeon would say, well, look, the patient is too sick, too frail, too old. We can't get them through the operation. And those patients, unfortunately, aortic stenosis, so a tightening of the aortic valve, is uniformly a fatal disease if untreated, typically within 2 years. So when you compare the mortality of aortic valve stenosis to the mortality of many of the common cancers that we treat in this country today, so breast cancer, prostate cancer, lung cancer, colon cancer, those malignancies that have already metastasized, and you say, well, who do you think is going to live longer if I give you 4 cancer patients with metastatic disease versus an aortic stenosis patient? Most patients will say, oh, well, the cancer patients are going to die first. Actually, it's the aortic stenosis patient that dies first. So we're very aggressive about treating aortic stenosis, but occasionally we were referred patients who were just far too old, far too sick, far too frail. And those patients would not be treated, and they would die of their aortic stenosis. They would die of heart failure. So we started in that population because, again, the conventional operation is a very safe and effective operation with long-term durability and an excellent safety profile. So once we proved that you could treat the inoperable patients and they did better than basically no treatment at all, we came down to high-risk patients. Once the studies showed that in high-risk patients you do better with a transcatheter valve than you do with surgery, we moved the clinical trials into what we call intermediate-risk patients. And most patients, the average 75-year-old with a couple of medical comorbidities, maybe a little lung disease from prior smoking, maybe borderline kidney function, most patients fit in that intermediate-risk category. And I was part of these clinical trials for both of the major valve companies, for Medtronic and for Edwards. And in that patient population, we found equivalency. We found that both are equivalent. So whether you have conventional surgery or you have a transcatheter valve, the risk of the operation and primarily the major risk of mortality or stroke were equivalent in the 2 arms. But here's the difference. With conventional surgery, we have 20-year data on the surgically implanted valves. For the transcatheter valves, we've only been doing it as worldwide for about 8 years. So we don't have the durability data on the valves. So, okay, most intermediate-risk patients are in their 70s. If we put a valve in and say devil's advocate, the valve only lasted 8 to 10 years. Now we get a patient into their early to mid-80s. Well, good news. Once we put a transcatheter valve in, you could actually repeat the procedure and do it again. So if you're 83 and you get another transcatheter valve, well, that's more than likely going to last you the rest of your life. Now take it to low-risk patients, and that's where the clinical trials went. Now, I was also part of these clinical trials as well. When you go into low-risk patients, so patients who are in their 60s who really don't have much in the way of medical comorbidities, if you do a transcatheter valve, say on a 60-year-old, we don't know, is that valve going to last as long as a surgical valve? We don't know the answer to that yet. And if you do it a second time, can you really do it a third time? Probably not. So in the low risk category, even though the clinical trials actually, one of them showed superiority to surgery in terms of mortality and stroke, but we still don't have the answer for long-term durability. And down the road, we could be setting ourselves up for having to operate on patients at a more advanced age who have already had a transcatheter valve. In addition,
go ahead.
In addition, so say you're 60 years old and you say, Doc, I really don't want to have surgery. And we hear this all the time. And you have a transcatheter valve, and that valve kind of sits kind of high in what we call the aortic root, and there's kind of a mesh. It's basically a stent with a valve inside of it. And now at 70, your valve is functioning fine, but you come into the ER with a heart attack. And the interventional cardiologist, they have to open up a coronary artery rapidly to preserve heart muscle and to stop the heart attack in its midst. There is some argument that with that valve in the way, cardiologists might not be able to access the coronary arteries as readily. Right now, we don't know the long-term effect of performing transcatheter valves in the young, low-risk population. And I'm an avid supporter of transcatheter valves. I've done around 1,500 of them. I was part of the early clinical trials, so I do both. Right. But the key is speaking to patients and educating to them and really giving your best advice for what you think is better for their particular scenario, for their particular age and their medical comorbidities.
Understood. So let me ask you a couple questions. It seems like the older patients are getting heart procedures like transcatheter aortic valve replacements more Correct. Now. So how is that possible?
How is it possible in terms of
that the
referral patterns, or
that the older patients are getting, that procedure more frequently?
Well, once transcatheter valves were proven effective, the primary care doctors and the cardiologists realized, well, wait a minute, there was a whole cohort of patients that they wouldn't refer because they felt that they were too old and too sick for conventional open heart surgery. And they may or may not have been correct. Now that we have transcatheter valve replacement available, we can treat virtually all patients with aortic stenosis, and therefore prevent patients from dying from heart failure from aortic stenosis. And it's not a pleasant way to live out your final days. Fluid builds up in your lungs, you can't breathe. So now that we have TAVR, so that stands for transcatheter aortic valve replacement, there's far more referrals from the primary care doctors and the cardiologists for the really elderly patients, the higher risk patients that we typically wouldn't perform surgery on.
Yeah, that begs another question. What criteria do you take into account when you're evaluating older patients?
The biggest criteria for me is functional status. So you could be referred an 88-year-old patient who continues to play golf 3 days a week, who drives, performs all their activities of daily living, and really is vibrant and full of life. Or you could be referred a 68-year-old who's had several strokes, bad lung disease from tobacco abuse, borderline kidney function, who is not functional. So who's the better candidate? They would both probably receive a transcatheter valve. The 88-year-old, even though being highly functional, you're 88 years old. I wouldn't want my 88-year-old mother or father to have open heart surgery if they could have a transcatheter valve. Now we're talking about a patient in the 60s with multiple medical comorbidities, disability, frailty. Well, that patient probably won't survive or do well after conventional open heart surgery, so that patient would get a TAVR as well. It's really all the patients in the middle that are the dilemma. Because every patient comes in the office, and I'm a big fan of an educated patient, and we're fortunate in the metropolitan area we have educated patients. They go on the internet, they Google their doctors, they Google procedures, they Google different hospital systems, and they all come in, and the first thing they say is, Doc, I don't want surgery, I want a TAVR. And sometimes they're right. But sometimes it's a 68-year-old patient with no medical comorbidities who may be better served from conventional surgery. Now, let's face it, the patient is in charge. And if the patient, I could educate the patient to the best of my ability. And if they still say, Doc, I understand, but I still would prefer to go with the transcatheter valve. Well, then the patient's going to get a transcatheter valve. The only subset of patients who right now who really should not get a transcatheter valve, no matter how hard the patient push is patients who are very young and have what's called a bicuspid aortic valve. So the normal aortic valve that 99% of the population is born with is a tri-leaflet or a 3-leaflet aortic valve that on echo looks like a Mercedes symbol or a P symbol. About 1% has a bicuspid valve, or bi for 2. And patients with bicuspid valve disease tend to have the generation of the valve at a younger age, so potentially in the 50s. And those patients are also known to have an associated connective tissue defect, and they develop aneurysms of the aorta. So that's where, remember before I said sometimes the valve we treat hand in hand with aneurysmal disease?
Yes.
And when you have a bicuspid valve, the transcatheter valves, we can put them in, but they were designed to go into a tri-leaflet valve. And a transcatheter valve will not treat a dilated aorta or an aortic aneurysm. So that patient population, unless there are multiple other medical comorbidities and as conventional surgery is unsafe, those patients should clearly have conventional surgery. And John Ritter from Three's Company, we all remember him. Yeah. Well, he passed away because he had not only a bicuspid valve, but unbeknownst to him, well, he didn't know he had a bicuspid valve because you don't find out until midlife when the valve gives you trouble. But he had an associated aneurysm sitting above that valve. And he had chest pain. He had shortness of breath. He was on the set of his new sitcom. He was doing a rehearsal. He literally was taken across the street to a hospital where they thought he was having a heart attack. By the time they realized, he's not having a heart attack, and they did a CAT scan, they not only realized that he had an aneurysm, but the aneurysm had torn, or called an aortic dissection. And by the time they got him into the operating room, he passed away on the operating room table. So patients who have bicuspid valve disease have a whole host of other issues potentially. And those patients, even when they come in and say, Doc, I absolutely don't want surgery, they really should not have a transcatheter valve unless there are really significant other medical comorbidities that will preclude a safe operation.
Well, you are listening to Healthy Lifestyle. I'm Lorianne Casdia, and we're going to come right back with Dr. Goncalves and hear more about this. I have a whole bunch of other questions that I want to ask you, so just hang on. We'll be right back. Welcome back to Healthy Lifestyle. I'm Lorianne Casdia. If you have any questions, comments, or ideas you'd like to hear more about, please email us at healthylifestylewithla@gmail.com. That's healthylifestylewithla@gmail.com. And of course, follow us on social media at Healthy Lifestyle with LA. We love hearing from you. We answer every email and post personally. And we're excited that we're going to start streaming live on Facebook shortly. So look for us there as well. We've been speaking with Dr. Goncalves, but you've been so amazingly informative, being that it's Heart Health Awareness Month. This has been really, really helpful. So I have a couple of other questions. We were talking about some symptoms and things like that. So first, I have to understand, for me, I'd like to understand, I think our listeners would like this, and actually somebody just asked me this question, how have minimally invasive surgeries changed since you started your career?
Oh, wow. That's a great question. So when I started my training and my career, pretty much every open heart procedure was a standard full sternotomy. In other words, opening the breastbone from, just at the bottom of the neck in the midline down to the xiphoid. That's right at the bottom of your chest, right where your upper belly starts. And that was every single operation. Then slowly but surely we started doing mini sternotomies where we would open just the top of the breastbone or sometimes just the bottom part of the breastbone. Then for certain valve disease, we would perform smaller incisions off to the side, so in the right side of the chest, and go between the ribs for either the aortic valve or the mitral valve. In terms of lung surgery, that's been dramatically different over the course of my career. So when I started again training in lung cancer surgery at Sloan Kettering, every operation was what's called a thoracotomy, and that's a relatively invasive incision along the back, kind of in a curvilinear fashion, following the ribs under the scapula. That's the wing that your arm is attached to in your back. Right. That's a very, very painful operation. Now, lung surgery primarily is performed with either thoracoscopy. That's where we put ports into the chest and a camera, and we do the procedure thoracoscopically. It's similar to, say, a laparoscopic gallbladder. Most patients have heard of that. And now even more lung operations are done robotically. So that's where the camera and the arms that go through those ports are controlled by a robot. And I actually performed the first robotic lung resection on Long Island years ago. I no longer do those surgeries because I'm so involved in aortic pathology, valvular disease, and coronary artery disease that you can't juggle everything. So I had to subspecialize a little bit more.
Wow. Oh my gosh, I have so many questions. I can't stop. So can you give us an overview of the Southside Heart and Lung Program? You mentioned lungs before, and what it offers.
So the great thing about coming to Southside is not only adding and expanding the Northwell Center for Aortic Disease out to Eastern Long Island, but Southside's cardiothoracic program is a comprehensive service that treats all aspects of cardiac pathology as well as pulmonary and lung pathology. I would say the only part of adult, again, not pediatric, adult cardiac surgical pathology that we don't treat is advanced heart failure that leads to things called assist devices or transplant. But being part of the Northwell system, we have Doctors Brian Lima and Harold Fernandez spearheading the transplant and assist device program in Manhasset. And with the resources that we have in the Northwell system, if we have a patient here at Southside that presents who needs advanced heart failure therapy, we have devices that we could temporize the patient with here, which are pretty standard now across the country. And then we're rapidly able to mobilize the resources and transfer those patients to Manhasset either by ambulance or by helicopter. Wow. To Manhasset. And one patient in particular, of course, I can't mention names. I remember him coming to us after having a large heart attack at Huntington Hospital. Also, another hospital within our family. He was treated there with stenting to the main blood vessel on the front of the heart. Unfortunately, about a week later, those stents closed down. He had a horrible disease, had yet another large heart attack. He came to us in what we call cardiogenic shock. So that's where the heart is not able to pump enough blood to sustain organs. So the heart is not pumping enough blood to keep your kidneys alive, your intestines alive, your brain alive, and so forth. We put a device in called an Impella, and that goes through the artery in the right arm with an incision underneath the clavicle. And that was pumping roughly 5 liters of blood for his heart, and that kept his kidneys alive and so forth. And then we transferred him by helicopter to Manhasset, where a different device was inserted to help support his right heart, and now he's actually on a transplant list.
Yeah, it's real important for heart services to be available out here in Southside. The Suffolk residents don't have to travel very far, right? And right?
Absolutely. Absolutely, and even if you look at aortic dissection, so that's what John Ritter passed away from. That's something that all aortic surgeons we try to prevent patients from having that complication. So an aortic dissection is basically the aorta, the main pipe coming off the heart, is made up of 4 layers. And I think we've all cut an onion in our life. So imagine 4 concentric onion rings. and you know how they easily peel apart. Patients who have aneurysms or the vessel becomes enlarged, whether it be from a bicuspid valve or family syndrome or a connective tissue disorder or just bad high blood pressure, when they develop an aneurysm, the glue between those four layers is not as firm, and just the sheer force of blood pumping out of the heart can tear between those layers like a pressure washer, and the blood starts flowing into the wall of the aorta, not just the main lumen in the center. That's called a dissection. And for those patients, about a half of patients who suffer a dissection die instantaneously. They feel a sharp pain, they pass away. The other half who make it to the hospital, the mortality for not treating them immediately is about 1 to 2% per hour. So if you're sitting in traffic, or you go to a small community hospital that A, first needs to make the diagnosis, then B, needs to find an institution who has a surgeon available who's capable of treating the patient, you're wasting valuable time, and the mortality just keeps going up. Within our system, and especially with the Center for Aortic Diseases, we have an aortic hotline, and the surrounding hospitals, they know to give us a call. We mobilize our transfer center, who can rapidly discover which of the hospitals in our system is available in terms of an open operating room and an available aortic surgeon, and we can get that patient to the right hospital, whether it be by the large ambulance service that we have that serves a significant portion of Long Island, even assisting the local government in transporting patients. But we also have our helicopter that we can rapidly bring patients from as far out as the Hamptons and Peconic, and they can be here within minutes. So that system is imperative, and it's fantastic that Northwell's been able to bring this out to the eastern region of Long Island.
Without a doubt. So what are some of the symptoms of heart issues that people often ignore but shouldn't?
I mean, the big one is that vague chest pressure, or just the sensation of being short of breath. Lots of times as we get older and we become, we're all victims of, being somewhat of a couch potatoes. As we get older, we become more lazy, and you start feeling, okay, well, I'm not as physically active. Maybe I'm just deconditioned, so I'm a little short of breath when I do things. And you could, human nature, you could really buy into that. And you see patients who the radius from which they do things around the home starts to decrease. They no longer do as much in a day because they become short of breath. And they just assume it's because they're getting older. But actually that may be underlying coronary disease masquerading as their anginal equivalent. In other words, they don't get chest pain. They're having shortness of breath.
Right.
Or it's valvular heart disease. That the valve is slowly getting tighter. I can't tell you how many times I've seen a patient in their 80s, in their late 70s with aortic stenosis, and they would have said, "Oh, doc, I just thought I was getting older." And then what's very gratifying is they get a new valve, whether it be surgically or with a transcatheter technique, and those patients, after they're fully recovered, come in and say, "Hey, doc, I feel 10 years younger. I didn't know I was supposed to feel this good." But they were ignoring the shortness of breath. Patients with coronary disease, they're ignoring that subtle chest pressure. Or that indigestion after a meal and saying, "Oh, it must be reflux." So those sorts of symptoms, you really need to, see your PCP on a regular basis, your primary care doctor, and look it's Heart Awareness Month. I think we would all do ourselves in society a great benefit if we started doing things more in moderation. So everyone asks me about nutrition, and I'm not a nutritionist, but I'm a firm believer in everything in moderation. So whether it be, meat in your diet, fat in your diet, fast food, which we really should, avoid. But look, I'm a surgeon. I'm busy. I'll partake when I need to. But everything in moderation. When it comes to tobacco, there's no moderation. Cigarettes, I tell patients, they're nails in your coffin. They need to go. But alcohol, moderation. Exercise, at minimum, it should be moderation. But several days a week, whether it be just a brisk walk, or if you're going to the gym, even better. But at minimum, walking. At work, I try my best to use the stairs, not use the elevator.
Yeah,
simple things like that.
I was going to ask you two questions. What should the average person, when should the average person start seeing a cardiologist? And also, what do you do personally to keep your heart healthy?
That's funny.
We need you around so that you can help us.
Yeah, sure. Well, in terms of when you should see your cardiologist, I would really leave that up to the primary care doctors. Not everyone needs to see a cardiologist, but the primary care doctor, should have your history and know, how long you have had high blood pressure. If you've had, they should be treating your cholesterol if it's elevated. The statin medications that we hear so much about are phenomenal drugs at bringing down cholesterol. So your primary care doctor would know when and if you need to start see a cardiologist, when and if you need a stress test, whether it be for screening because of risk factors or because of symptoms, and then the cardiologist will decide whether the stress test is sufficiently, negative or whether or not you need to go on for more invasive testings. In terms of what do I do to become healthy?
Yes.
I married a wonderful woman who makes sure that I eat well. She changed my diet dramatically. So she makes sure that I have several helpings of fruits and vegetables every day. I'll be honest with you, prior to my marrying my wife, that was not my routine. She introduced fish into my diet. That was also not my routine. More chicken than beef, although I certainly enjoy steak. But if you look at steak, certainly I would love a ribeye, but a ribeye is delicious because it's all marbled with fat. Filet mignon is relatively lean. So if you're going to have red meat, which again, everything in moderation, there are different cuts of meat that you could eat that are better for you. In terms of exercise, same thing. I try to use the stairs when I can. I try at least 2 to 3, if not 4 days a week, to do a half an hour of aerobic exercise. And again, that was my wife prodding me to get into shape because she's an avid exerciser. And I just turned 50 and I've got a baby on the way any moment now. So I say to myself, well, wait a minute, I'm in that age group and I want to be around for my child. So,
and this is your 5th child, right? On the way?
This is my 5th, yes.
We're actually waiting for the call potentially. Yeah,
she just did text. She just did send me a text, and all she said was hi, so it wasn't an emergency. So I can stay on the line.
So we'll finish this up. With that said, there's a few different kinds of heart specialists: cardiologist, electrophysiologist, and you're obviously a cardiothoracic surgeon. What's the difference between all these fancy schmancy names? Because I know you're all very specialized. So how do I know who I should be going to, and what's the difference between them?
Sure. So a cardiologist, they treat all aspects, and even within cardiologists, there are specialists, that will, hone in on specific disease entities. But a general cardiologist is someone who treats cardiac disease medically. So that would be, with, controlling blood pressure, controlling cholesterol, and treating heart failure with different heart failure regimens, including newer drugs like Entresto and diuretics and ACE inhibitors and so forth. They're also the ones that would diagnose more advanced pathology, maybe send you for a stress test or an echo. If the stress test or the echo showed something, more troubling, they may send you to an interventional cardiologist, and that kind of sums it up there with the word interventional. So an interventional cardiologist, they're the ones who do the cardiac catheterizations. They're the ones who put stents into the coronary arteries, either acutely for a heart attack or electively for a patient who's having chest pain and failed a stress test and is found to have a single blocked artery, and they'll put stents in. An electrophysiologist is a cardiologist who is trained as a medical cardiologist, but now they've subspecialized into treatment of the electrical system of the heart. So I'm the plumber, they're the electricians, and they treat the electrical system of the heart, and they treat aspects of arrhythmias, where they may treat with medications, or they may treat arrhythmias of the heart with ablations. In other words, coming up into the heart with catheters, either into the venous system or the arterial system, and ablate. So they take catheters and they burn inside areas of the heart where they know there are foci that are causing arrhythmias. They treat atrial fibrillation that way. They also put pacemakers in and defibrillators and so forth. And then obviously a cardiothoracic surgeon, we're the group of physicians who do coronary surgery, so the classic bypass operation, valvular repair, and valve replacement. I have to say, just as in terms of valve repair, I'm here with Dr. Robert Kalimi, and hands down, I believe Dr. Kalimi is the best mitral valve surgeon I have seen. So So we get referrals from all over the island for patients with complex mitral valve disease, and they either undergo conventional surgical repair, sometimes replacement, but more often than not repair. And you're always better being left with the valve that God gave you than a new one that we're going to put in. Or minimally invasive techniques such as a mitral valve clip, and that's where you go through the groin and you clip the valve leaflets together to decrease the regurgitation of the leak. So I'm very pleased to be working with Dr. Kalimi.
We're very pleased that we have you accessible here on Long Island. In the last few minutes, let me ask you, Doc, why? What's your why? Why did you get into heart surgery?
That's another great question. So when I started in medical school, I always said I went to medical school saying I wanted to be an orthopedic surgeon. That probably comes from my personal experience when I was younger. I was diving off everything I could find, and I was breaking bones left and right. So I was, kind of a science guy, and I figured, okay, I'm going to be a doctor, but I'm going to be an orthopedic surgeon. I was always very handy doing things around the house with my dad. And then I went to medical school, and I saw, neurosurgery, and I'm like, oh, I'm going to be a neurosurgeon. I'm going to do back surgery, and I actually had my applications out, and then I did a 2-week elective in the open heart unit, and that changed everything. Once I was, as a student, they make you hold the heart as the surgeons are doing the bypass surgery, and the first time I held the heart, I came home and told my then fiance, well, I'm kind of stuck now. She's like, what do you mean? I said, well, I'm not going to go into neurosurgery, and now I've got to go and I'm going to be a cardiac surgeon, and that it's a whole different training path, far more years. It was, rather than doing 5 years of neurosurgery, it was 5 years of general surgery, 2 years of taking off time and doing research, just so you could get the fellowship, then 2 more years of fellowship. So it turned into a 9-year training track, but it was the best decision I ever made.
Wow.
No one else has the privilege of holding people's hearts in their hands, so I'm blessed.
Oh my gosh, that is such a great why. I really, we're blessed. Thank you so very much. Thank you for joining us today. I really appreciate it. I know our listeners are going to be really well informed with this, and it's nice to know that you guys are right in our backyard, right and accessible. So thank you all for joining us today on Healthy Lifestyle. My heart is lifted by sharing this time with you. I want to thank you, Dr. Goncalves. Thank you so much.
You're getting it.
I'm getting it. It's a little faster. So
thanks for having me.
Oh, it's absolutely our pleasure. I always want to thank our producer. In the meantime, follow us on social media, send comments, interesting topics that you want to hear. We'll always connect you up with people that you find interesting on our show. We are here to serve one another, as we always say here. So take a moment. Step out of your day, do a little something for someone else. It'll make you feel really better. And also remember, do a little something for yourself every day. It takes 21 days to build a habit and 90 days to build a lifestyle. So start with one new habit this week and give it a try and see if you can go for 21 days. You'll really appreciate the difference. Create that new habit. Thank you again for joining us on Healthy Lifestyle. I'm Lorianne Casdia. Until next time, play a higher role, serve a higher purpose, show up for you, and show up big.